Welcome to Tackling Antimicrobial Resistance, a new NIHR podcast series that aims to shine a light on the threat posed by antimicrobial resistance to UK and global healthcare and the role research can play in tackling that threat. I'm William Hope. I'm the Dame Sally Davies Chair of AMR Research at the University of Liverpool and also the co-lead for infection at NIHR. Each week I'll be talking to experts in antimicrobial resistance to get their views on what can and should be done to tackle AMR as the NIHR brings together stakeholders to create a UK-wide approach. Hello, everybody. It is my very great pleasure to invite today for this NIHR CRN podcast, the Chief Medical Advisor for the UK HSA, Dr. Susan Hopkins. Welcome, Susan.
Thank you, William.
So I thought we have a number of questions. We have about 45 minutes, Susan, to discuss a whole range of things, but it would be nice to hear from you about your career and how you rose to such a prominent position in the UK. Can you tell us about your training and important points in your career path?
Yeah, I suppose we don't reflect very much on this, but I trained in Ireland, so in Trinity College Dublin, and then subsequently in a range of hospitals around Ireland. And I came into infectious diseases predominantly because I thought I'd like to go overseas and do some work in overseas countries. And so after I had done my core training as a house officer and as an SHO in those days, foundation year in core medical training these days, I went into infectious diseases. I think it wasn't though a simple one-stop binary decision. I was always interested in complex multidisciplinary type roles, and I suppose I'd had exposure for renal and oncology, who have got lots of similarities and have got lots of infectious diseases involved in them. And until I decided that I'd like to do overseas work, they were probably the areas that I was heading to. But I had spent time in the tropics as a medical student, and particularly was really interested in the care of HIV and AIDS in the tropics at that point. So when an opportunity came to do a HIV predominant job and an infectious diseases job in Dublin, that's where I started from. I think just on a reflection, when I look back, even at the starting point in my first weeks of those jobs, I was very interested in the epidemiology of disease. So within my very first few weeks of starting in that job, I was also doing some sexual health clinics, which I'd never done before, and saw cases of primary and secondary syphilis. And when I asked my colleagues, was this common? They went, well, we don't really think so. So I did a 10-year look back of how many cases they'd seen and presented the epidemiology to show that there was an outbreak happening in men who have sex with men in Dublin. So right from the very outset, I think I was interested in understanding trends, who was affected by disease, and how that happened. And equally, very early on, I started to see ciprofloxacin resistance emerge in gonorrhea in Ireland, and again looked back and described where that was emerging from, what were the particular factors, how travel was associated with that disease. So I think, you don't often realize where you're going to be in 20 years hence when you start your career. But it was clear I was interested in the individuals and the disease and the clinical syndrome. But also I was really interested in understanding those diseases better and using data to help us derive better outcomes for our patients. After I had done my initial training in Ireland, I spent time in Seattle doing a fellowship on syphilis and doing molecular diagnostics in syphilis when it was really quite difficult. And I have to say, we didn't really succeed trying to understand the relatedness of strains. And actually, the only outcome from that was to show that syphilis had emerged as having macrolide resistance at that point in time. And that may have been one of the reasons and drivers for our syphilis outbreak. It was very different what we saw in those individuals with macrolide resistance in Ireland compared to some other countries around the world. And then after that, I went to Paris and did a HIV fellowship before coming to London. And I think when I came to London, I recognized that there was a lot of work happening in HIV, and there was actually very established disease groups. And at that point in the UK, there was very well-established outbreaks of MRSA and C. diff and other drug-resistant infections. And again, going back into my understanding of what was that, I spent quite a bit of time in my last year of training in the UK trying to understand the disease burden of infectious diseases that were happening as healthcare associated infections, and sort of took a switch from doing much more HIV, STI type diseases to looking at healthcare associated infections and antimicrobial resistance. I think when you look at where I am now, it's always a way of falling into these things. As a clinician at the Royal Free Hospital, we had a high consequence infectious diseases unit. So had managed everything from Ebola, Lassa, SARS and MERS over the years. And so when the initial outbreak was highlighted in Wuhan in China, I offered my assistance thinking that this was going to be a SARS-like outbreak in very early January 2020. Little did I know at that point in January 2020 what was going to happen and how the world was going to be affected by the pandemic. And I think that I was able to bring together my clinical skills and my work in the NHS, my research skills that I had done over the years on a wide variety of infectious diseases, and then an understanding of how the system worked from the department, from what was then Public Health England and the NHS, to help integrate those systems in managing the public health and health problem that was COVID-19.
So where, Susan, did the bridge from being in a clinic and being interested by a cluster to your ability to think across or at a system-wide level, where did that happen, do you think?
Well, I think right from the start. So that very first syphilis cases, as a first-year registrar, I was suddenly involved in the national IMT and, wondering about what are the interventions we were going to do and deliver, and coming up with, at that point, which was the Gay Men's Health Project in Dublin, similar to the Terence Higgins Trust here in the UK, working with them to develop interventions in the community. We actually went into saunas and tested people. So I was always interested in working for the best outcome for patients and not worrying so much about where I needed to be located and how that needed to be done. And so didn't really ever feel that I needed to be straight-laced into having one career or the other. I also felt I like gaining knowledge. I like working with people and never really understood the sort of hierarchy of systems. Thought the best thing to do was to reach out, talk to people, engage. And I think that has stood me in good stead in engaging across the system for antimicrobial resistance in particular, with primary care, secondary care, social researchers, policy colleagues, as well as epidemiologists and data scientists. So I think it's not seeing yourself as constrained to a box. Understanding that you have influence and a voice, and at each point using that for the best outcomes for patients.
Do you think that that's intrinsic, or do you think that that's learned, that ability?
So I think that we all have different characteristics in how we behave, but I also think that it's an important characteristic that we need to develop in our clinical staff and our research staff, that they don't see themselves working just within one group or just having a sphere of influence that is right there in front of them. I think they need people, and we see this very widely, I think, in the research community, where you often start thinking that you can only inject into a small area. But as we develop and grow, we realize that we can reach out to very many different types of people and influence across lots of different areas. So I think we all have it, and I think we have to just give people the skill set to develop that even further.
Maybe we all have it, but like you say, it's easy to drum it out of people by the way we organize ourselves. Maybe that is true. Now, so I'd like you to describe for everybody what UKHSA stands for, what it does, and how it fits into the landscape of healthcare provision and protection in the UK. Could you do that for us?
Yeah, so UK Health Security Agency was formed in October 2021 as a part of the sort of pandemic legacy. And its job is to protect the public in the UK from infectious diseases and other external health threats, particularly chemical, radiation and environment threats. It has a particular remit to detect diseases, analyse and understand them, come up with ways of preventing them, but also leading the system in that approach. And we work across the Department of Health, with the Department of Health very closely. We're an operationally autonomous executive agency, and that sounds like a mouthful. What it means is that we are civil servants. We work as part of the civil service, but that the work that we do and how we deliver it is delivered by us in whatever way we believe is the right thing to do. We work very, very closely with the NHS, and the NHS look at us as the key partner in the delivery of infectious diseases and health protection. And so we help and support the NHS in their management of patients and in contact tracing in the community. But equally, we provide support to local authorities and directors of public health in their statutory role at a local level. So very much we are system leaders. That means that we present the evidence. We show where the research needs to be done to the research funders, and we highlight the actions that people need to take. And in some situations, in some parts of that, those are actions that are for us to take, but others it's important that we call out where other action needs to take as well.
And how does, so the funding of UKHSA and the ultimate reporting of UKHSA happens through what mechanism?
So the majority of UKHSA's funding is from the government. So similar to the NHS in many ways, the vast majority of our funding comes from there. And that funding is there for us to deliver our core remit across the wide variety of infectious diseases, threats, and chemical radiation and environmental hazards. And with that, we are responsible for having national reference laboratory functions. Mm-hmm. So we are there to provide the ability to do things that wouldn't happen within every lab or within even every region. So special tests that might be rare or unusual, because we're able to validate and do those. We're also there to provide specialist typing or molecular typing of whatever form to understand if the strains are there are an incident or an outbreak that might be taking place and how that might be transmitting. We also collect a wide remit of data that helps the NHS understand what it's doing and performing better, and releasing that to both understand how we're performing and also evaluate the interventions that we're delivering.
And Susan, the counterparts for many infectious diseases don't respect borders, or all of them don't respect borders. So the counterparts in, well, it's the United States, first of all. Who would you pick up the phone to? Which organization in the United States?
So we have very close relationships with the Centre for Disease Control, and actually those have been strengthened through the COVID-19 pandemic. Often we had relationships at a working level, but we now very much talk to their executive team on a regular basis. We also have relationships with other national disease centres or national public health institutes in other countries across Europe, Australia, Singapore, South Korea, for example. But we also very much work closely with WHO, World Health Organization, Europe, and the central office in Geneva. And prior to Brexit, we worked very closely with the European Centres of Disease Control, and we have a memorandum of understanding agreement with them to ensure that we have close relationships in managing cross-border threats.
So a web, an international web. I want, so you mentioned the beginning of 2020, and I want to take you back to those first few months of 2020 and ask you, I mean, I'll tell you what I thought. I thought that this was a big wave approaching. We'd all duck under it and pop out the other side. And well, I was about as wrong as I could be on any of that. What did you think back in January and February of March 2020?
So I think, as I said earlier, in January 2020, when the first cases, I felt that this novel coronavirus could be very much like a SARS-like. I thought it was much bigger than MERS. We were seeing some human-to-human transmission, which has been, different to other viruses that have come in a zoonotic approach. So we were definitely concerned. I think that when we started seeing cases in other countries, the concern was growing. We were concerned that cases could be happening anywhere in the world and we wouldn't be able to detect them. When the first two cases happened in Lombardy, Italy, I think at that point I went, we've got a major problem. if those two cases are happening in a small area of Italy that isn't very well connected, it's not a capital city, then it is everywhere. And I'm pretty clear at that point, I thought we were forwarding into a 2-year pandemic. So mid-February, I think that I was pretty clear that this is going to be a 2-year long haul. And I recognized that we knew very little. And I did not, I think, at that point understand the scale of the human factors disaster that we saw, the scale of the health challenge that we were going to have, and also the economic and social challenges that were going to ensue. I don't think we could have imagined that. I don't think in our recent memories that we've had anything to this scale or extent. And I spent quite a bit of time in those first few months reading back on old pandemics, but it's hard to believe that something that happened in 1918, which is probably the most similar. All of the other flu pandemics of the last century didn't seem to come anywhere near causing the same amount of social harm that caused by this, that it was hard to believe that with all of the advances we'd seen in healthcare, that we were not going to be able to manage it better. And I think that shows how potentially complacent the world was, and also how different the world is now compared to then, and actually how connected and how difficult it is to break those connections with the world.
Yeah, I'd like you to reflect then on, I have a stark memory one Sunday morning of seeing you on television, I don't know which one, but proclaiming about the summer holidays and trying to be Cassandra-like about summer holidays. I can remember that. And so I want to ask you then about all of the learnings. Well, what were the 3 big things that we now are much better at in terms of, well, up to 3 things? How are we better and smarter and more resilient now than we were at the beginning of 2020, do you think? What are the major learnings?
Well, I think it will take us a full length of time to understand that better. I think one of the key learnings for me is the close interaction by the impact of health and healthcare on the wider impact of the economy. Mm-hmm. I think we have all talked about this in reference to pandemics, and we've talked about it with the O'Neill report for antimicrobial resistance. But I don't think we've seen it in such stark in front of us as we have with this pandemic. And that tells me that we need government to understand the scale and extent and how fast infectious diseases can spread, and that the whole system and the whole part of government needs to be involved in preparing for the next pandemic. It's not just a health issue. So that's probably the first big thing. The second is the power of data. Clearly, what we learned very rapidly is that understanding the scale and extent of the infection, not just in this country, but around the world, the extent of how it was infecting people, the people that were being affected by it, the health inequalities, the impact of trials and studies, would really allow us to understand this better. So I take data in the broadest sense of surveillance, in terms of cohort studies, in terms of randomized controlled trials, in terms of data sharing as a critical enabler of what we can learn from this and do better on. And the final, I think it brought into stark relief health inequalities and disparities, and how I think us who work in infectious diseases always recognize that infectious diseases have disproportionate impacts on the population, be those with immunocompromised, be those that are older or very young, or be those that have socioeconomic deprivation for many different reasons, that was brought into focus here again. So I think this comes back to one of my earlier points, is that we can't work in silos. We can't just think about the patient we're treating in front of us without trying to optimize our impact on all of those other areas, if we are truly to make step changes in the health outcomes of the population. Yeah,
I think that's what the pandemic did for me as well. I was perfectly happy in a little biomedical bubble that I existed in, but realizing that all the problems we dealt with were system-wide, as you say, and that turns out to be quite liberating when you think about that, because you make a whole lot of new friends and you're exposed to a whole lot of new ideas. And I wonder whether, so now it would enable us to start talking about AMR. You already mentioned drug resistance with ciprofloxacin, so we should tell everybody ciprofloxacin is a commonly used antibiotic, and you notice that some of your patients with gonorrhea had ciprofloxacin resistance, which means that that drug no longer works. So I just want, so the three things, Susan: health, the connection between health and wealth, the power of data, and inequalities. Can you, do they also apply for AMR, do you think, antimicrobial resistance?
Yeah, well, firstly, hugely. So I think I'll pick the data aspect first. So, I think we have been working, and we're still working, in a relatively data-poor world for antimicrobial resistance. We do not understand, and the importance of what people have been exposed to in the environment, in their food, in the water they drink on a daily basis, in the people they meet, and how that may impact them and cause an infection later on. We also don't understand the full impact of all of our life experiences on our antimicrobial resistant infections that may happen down the line. We're starting to understand, for example, that those babies born by cesarean section have a different microbiome from the moment they're born, and that may impact how they respond to infectious diseases, immunology, and and obesity. So I think that we need to understand that we live in a complex world with bacteria and viruses, and that the interaction of all of those together can cause a health impact that is much greater than just an infection. But equally, that it is understanding all of that in a much more holistic way will allow us to get better interventions. We've often looked at infectious diseases in a very simple paradigm of, you get a bacteria, you get an infection, you treat it, and you get the outcome. There's sort of susceptible, infected, and cured, or results of that infection. But I think particularly for many of the bacterial infections that are developing resistance these days, we live in a happy equilibrium with them, and we don't really understand what that means. And we don't, I think if I then go on to inequalities, so we know, for example, that different parts of the world have different types of resistant infections. So individuals coming from different parts of the world have different infections. We know that different extremes and different populations of age are more likely to have drug-resistant infections. Neonates and those born prematurely are a particular risk in the young. And then in the elderly, with probably cumulative exposure to antibiotics over the years, increased amounts of exposure to the hospital environment, which is a hotbed of how we can exchange genetic information and bacteria. And then the multiple other components of the lifestyle we lead, and of the factors that we have within ourselves, can all drive antimicrobial resistance. And I think we should highlight, particularly, for example, how people live, the houses they live in, how well sanitation is, water exposure, and, for example, the mold in households that was brought again into the newspapers with the sad death of a child, shows that our living and the way we live, the people that we've been exposed to, how close we live with them, the antibiotics and the conditions that we have, all impact on antimicrobial resistance. So we've really just scratched the surface, and we need to understand all of that better. And in a way, over the last 50 years, we keep putting sticking plasters on antimicrobial resistance. Develop a new drug, use that new drug to treat people, all will be good. But actually, we have to understand the system if we really want to make this a lasting legacy, and think about it in a different way.
Right. So there's a lot to unpack just there. I think there's a definition of insanity, isn't there? And I think that's your point, and you've always said it about, we just can't get through this by continually making new drugs, even though I think you will admit that we do need continual or ongoing innovation. That for sure is part of what we need to do, but that is not the solution. So let's just try and unpick some of this a little bit. So I think that just to say some of this back to you, Susan, you started talking about One Health. You didn't use those words, but that is this idea that AMR is not just a human problem, it's a It's also important for food security. It's important for animal health and environmental sustainability. Do you want to just talk about that a little bit more? And does UKHSA have a role in those domains as well?
Yeah, so I think, I mean, One Health is an often used term, and I think it can be quite difficult for people to understand where they fit in. And I think One Health is really often used in AMR, but can be used in any other aspect of what we're trying to do. And that basically says that humans, animals, the environment all live together, and therefore we all have a role to play. UKHSA works very closely in the UK with the DEFRA, so the Department for Environment, Food and Rural Affairs, and also the Food Standard Agency to work and look at where we can work together on understanding the different threats that sit in the different components of where we are working from. We know that particularly, for example, that the sanitation has been important as an example of where you release sewage into water that could cause more bacteria and resistant bacteria to get into the water. We can get that into our food by how the food is the animals live. We can get that into back into humans by how they eat. But I think it's much wider than that, actually, in terms of we need to think about One Health, not just, again, within a UK context, but within a global context. And again, from my point of view, we often concentrate on the simple interface on some of those, rather than the much more complex interface that might exist when people live much closer to animals in certain parts of the world.
That's right. So, I was in Malawi recently, and a colleague of ours, Nick Feasy, was able to describe very beautifully the transmission in the environment of resistance mechanisms, maybe because of what you said about living closely with animals. So you mentioned at the start of that, trying to describe the complexity, Susan, about data. And I want to come back to data because I'd like you to describe nirvana in terms of what data looks like. And maybe, it's one of those disclaimers that you put on your Twitter account. These are my personal views and not necessarily the UKHSA, maybe. But what does, I'm fascinated by this covenant, this relationship between individual rights, to own our data and to have privacy, versus the arguments that you're trying to make that we're all in this together and we're part of a very complex ecosystem. And that tension, if you like, is highlighted by data. So do you have a view about what that looks like?
Yeah, so my view is that, first of all, just in speaking about data and in speaking about data to the public, we have a work to do and continue to do to explain to them how we will use their data safely and effectively. And we will protect them and protect their data in whatever way we can, while ensuring that we gain the maximum amount of knowledge out of it to inform what has happened in the past, but what also may happen in the future. And I think that that's a really important and critical bit for us as organizations who work with people's data on a regular basis. Secondly, I think that we in the UK have a wealth of data in comparison to some other countries, but not as good as other countries. So I would pull out Scandinavia as a particularly good example. And one might say it's because they're a bit smaller and it's easier to do in a smaller network. But I do believe that we should be able to at least understand the events that happen to people in their lives in healthcare, even if it's not the wider events that happen, so that we can start to understand and unpick how those healthcare events may relate to antimicrobial resistance. I do also think that we need to understand their antibiotics prescriptions that they've had at an individual level, to understand how that may be better, which ones may work better, which ones may not. And I think it's only with high levels of very granular population data that you can start to understand it and then develop hypotheses that you can test. And so that's a very different phase of, starting to understand it. And I also think that then on top of that, what we, in the optimal ideal world scenario, we would constantly be thinking about the sampling frames or the populations that we need to study, be that in the human populations, the animal populations, environmental sampling from wastewater or soil sampling, so that we started to actually have it in a systematic way. And understood that better. And I think, again, we've learned a lot from the coronavirus infection survey, but we've also learned how expensive it is. And the investment into understanding the impact of antibiotic resistance on all of those components will help us to drive better interventions in both the population of humans, but also in interventions at a societal level from a One Health approach. So my view is that we have taken great steps forward. I think the data that we have now compared to 10 years ago is vastly improved. I mean, 10 years ago, we had no idea on a systematic way how much antibiotics were being used in this country. Or, it was in little pockets, but we weren't surfacing it. And I will highlight the English Surveillance Programme for Antimicrobial Use and Resistance report, which actually highlights the progress that we've made on understanding antibiotic use and driving it down. So we're almost 20% lower in antibiotic use now than we were 10 years ago, because we were measuring it and we were doing something about it. So I think the power of data allows you to drive change, drive evaluations, improve things, and focus your attention on certain areas. But that we need to get better at providing proper sampling frames for the population so that we understand it better in an unbiased way.
But maybe though, so you described there the surveillance that's required and the use of antibiotics, or how many kilos of antibiotics are making their way into humans and animals in the environment. And like you say, that's far from trivial and it's expensive, but it doesn't really pose necessarily too many ethical issues. So what about, where do you think the UK population is in terms of enabling their own personal data to be used for themselves to advance their own cause and their own personal healthcare, but also as a trade, if you like, to make the very next person that needs that antibiotic able to benefit from that? Where is that debate, do you think?
So I think COVID has helped people understand why data is really important. And I think that's been really useful. I also think that we have a number of large programs of work that are taking place to allow people to understand how we use that data better. And that's the right thing to do. I think that we have a large amount of primary care practices that are networked and that are able to share their data either in an anonymized or pseudonymized fashion, and in some cases with full data linkage to other data sets. And we've seen that, for example, with Open Safely and its use of data to be able to look at COVID, but with the actual patient records and other factors. So I think we have moved ourselves on. I think we still do not have adequate timely access to data from hospitals. And that's partly because of the information systems that are available and the skills required to extract that data from hospital systems. So I think we need to recognize the importance of data in healthcare, in hospitals in particular, and ensure that we invest in both the systems, making sure the systems are right, that people are trained on them, that they're the right systems, but that we also have people who can interrogate those systems and that we can provide standards for those systems to use so that they're comparable across different organizations.
Thank you. I think that for people that are listening to this, that is a lifetime of work that you're describing, but it's absolutely mission critical that this work continues at all levels. So those people that are interested in computer science, data engineers, data science, ethicists, all have a role in this. This is the transformation in healthcare, at least in my view, that's going to happen in the next 10 or 20 years, this data revolution. Okay, I want to pick up something else that happened in the pandemic, and it's this idea of test to treat. So that is that you actually have to have a test that you do to inform actions, whether that's to take a drug or whether that means that you have to isolate. And maybe, Susan, you can maybe shock our audience by sort of telling everyone how little test to treat there is for AMR, or can you describe that problem? Because that really is a major problem that we're facing.
Yeah, well, I mean, I think the steps we've taken in diagnostics in the pandemic has been amazing. Yes. From the fact that we were able to scale PCR testing to close to 1 million PCR tests available at their maximum peak at one point, to lateral flow rapid diagnostics with a result available in 10 minutes, to the ability to be able to give those results back to individuals and into their health records, into their NHS app, and into the national surveillance system within minutes, has been a phenomenal achievement. From the point of view of other infections, so the vast majority of infections in this country and in almost all other countries are treated in primary care, and almost none of them have a diagnostic test. And part of the reasons for that is because they're based on clinical syndrome, and we treat the clinical syndrome depending on how unwell people are. And there's lots of tools out there about how to treat individuals to reduce antibiotic prescribing or to prevent prescribing where it's inappropriate. But even in hospitals, the vast majority of individuals who come into hospital with infections may have a diagnostic test, but probably about 1 in 4 actually have a diagnostic test that gives them a result that allows them to focus where that is there. So it shows that we have this huge gap from getting to the point where we prescribe an antibiotic for a syndrome to prescribing an antibiotic based on a result that actually tells us which antibiotic we should use and why we should use that particular antibiotic where we are now. I think that, I'm very keen that point of care diagnostics that we've now used, but we've used in a way that is disruptive to the healthcare system, needs to be brought back into the healthcare system to some point, so that either people can do them at home, but then they can go and show them to their doctor on their app or their healthcare professional, so that they can prescribe, or that it has been able to be delivered at the point where they're getting their healthcare attended to, if they're at a face-to-face appointment, and they can get healthcare delivered. And I think we are a long way away from being able to do that for all infections. But I think where we've got other infections where we either have a lot of drug resistance present, and I think I would call out urinary tract infections for that, where if we had a simple diagnostic test that told you could give a simple first-line antibiotic and that was safe, that would be really, really helpful. Or in respiratory tract infections, where a lot of them are viruses. And if we can tell you that you have a virus and not give an antibiotic, that would be extremely helpful too. I really would like to see continued investment in the diagnostic space. And I would like to see a paradigm shift into thinking about how we use diagnostics that are cheap and timely to help us treat our patients better.
So can I just go back on a few points of clarification for those that are listening that are not clinicians? A syndrome is what? What do you mean by syndrome?
A syndrome is a collection of symptoms that people may have or signs that we may elicit on examination that allows us to define what condition the individual may have. So it may be that it's a cough and a runny nose or a sore throat, or it may be that it is for a urinary tract infection, stinging when passing urine, or frequency when passing urine, or blood in the urine, that allows us to be able to define what sort of condition the individual has.
And you said the word, Susan, disruptive, which many people will take as a negative word, considering recent politicians, mainly in the United States. But you didn't mean that. You meant this in a positive way, didn't you? So just when you say disruptive, just tell us what you mean by technologies that could radically change how we behave.
Yeah, so I think, medicine and healthcare delivery has many hundreds of years behind it and how we think about and deliver healthcare. And in order to change how we deliver it, from we diagnose a syndrome, we give an antibiotic, to something that is different, it has to be disruptive. It has to be pretty life-changing in what we're doing in order to really make a step change difference. Otherwise, we're making small increments, but we won't really change it. So if we got to the point, which for those of you who read the O'Neill report a number of years ago, said only people should get an antibiotic if they'd had a diagnostic test beforehand. That was a pretty disruptive statement. But in COVID, we got to the point where actually only people get COVID treatment if they got a COVID diagnostic beforehand. For the first time ever in my lifetime on how we give something, some treatment for quick and acute illness, slightly different for chronic illnesses and chronic infections and other things like that. But for something that could be delivered within 24 hours, I think this is at a large scale to a population. It was also the first time that we gave an instruction to people based on the result of a positive test. For example, in previous flu pandemics, it would have been, if you feel unwell, stay at home, which was the starting point in this pandemic as well, but moved very rapidly to much more about diagnostic testing. And I think that disruptive technology that we used in COVID-19 has a real place in healthcare as we move forward.
And so let me just test an idea out on you. You've spoken a lot about data. Could data be a diagnostic? Could you use data to be a diagnostic? Because we often think of it's a test that you do. It's a lateral flow, or you send something to the laboratory. That's what we often think as a diagnostic, but it's not, is it? It could be much broader than.
So I agree, it could be much broader. And I definitely think that we can use AI in particular, so artificial intelligence, to help us better. So, but I think that actually, if you really want to move things forward, it needs to be more than just, well, here's a diagnostic test that is a syndrome-specific diagnostic test. It has to be more than that. It has to be more technology enabled. We have to be able to validate it better in real time, and we have to be able to do studies or randomized controlled trials to see if it works. And I think that's probably the bit that we didn't do so well in lots of areas, but I would call out 2 randomized controlled trials we were able to deliver with lateral flow tests for COVID. One was in schools, to show that if you did delivered randomized control tests, you could keep children in school just as much and stop whole classes going home. And the second was being able to use lateral flow tests to allow people out and about. So a test on a daily basis and being let out was just as effective as telling people they must stay at home for a period of time. So I would also really like to see us using platform trials and pragmatic randomized controlled trials to test diagnostics better, be that a tool, be that artificial intelligence, or be that a more traditional diagnostic test, so that we have good evidence that they're going to work.
So Susan, we're sort of getting to the end of our time today. I just wonder, part of the reason for doing these interviews is a call to arms, really, to highlight to people that there are actually fantastic problems to solve that are going to be important for the health and wealth of all of us, as you so eloquently have said. So just fast forward 10 years. What does that look like in 10 years for AMR, do you think?
So, I mean, first of all, I think from the point of view of antimicrobial resistance, I do say to people, staying still is a good outcome. Okay. And I think that's really, not everywhere and not in all places and not for all bacteria and viruses. But you know, I think we need to talk about AMR in a similar way that we talk about climate change. So where we don't say to the governments of the world, you need to reverse AMR, because that's particularly challenging. But we at least need to say, this is the area that we're at, and we need to do more things to make sure that we stay there. And so I would first of all call out that I think in the last 5 to 7 years, since we've had strategies and AMR national action plans, that has helped focus our minds in this country a little bit to at least stay at the same place. I then think I would make a call to arms that this is not an infectious diseases clinician and epidemiologist problem alone. This requires thinking from and input from a very wide range of specialisms. I think that we need to think about this from a social science, behavioral science, economic science, and laboratory science, as well as the sort of elements that we've spoken a lot about here today from where I come from. And I think that if I could look forward in 10 years, we would have engaged widely from a very large range of specialisms, academia, industry, clinicians, and the third sector and the humans of the world, where they believe it's a problem. They want to do things to fix it. They're looking at lots of innovative ways to do it, and that we are in a position where we are no worse than we are today, and in some parts of the world better.
I think that is an incredibly optimistic statement, and it's that, you know, I think that the call to arms for it's a system-wide problem that's going to need all sorts of creative solutions, and I could not agree with that more. And that seems, Susan, like a very good place for us to stop and to thank you for a fantastic discussion. I really enjoyed that. Thank you for all of your contributions over the last few years. We all owe you a huge debt, and long may that continue. Thank you very much, Susan.
Thank you very much.
Thank you for listening to this episode of Tackling Antimicrobial Resistance, a short NIHR podcast series hosted by me, Professor William Hope. If you have any thoughts or comments on this or any other episode, please contact us via our Twitter channel at NIHR Community. And for more information about the NIHR, you can visit our website, nihr.ac.uk.